All right, we're going to get started, folks. I know people are filtering in, but we're going to begin because we have with us, we're very fortunate to have with us Dr. Mandy Cohen, and so we want to make sure we use her time wisely. We have with her, she has a half hour with us till 1:30. And so my name is Terry Allan. I'm the Health Commissioner at the Cuyahoga County Health Department in Greater Cleveland and a member of the Roundtable. And so we all know and have appreciated Gary's Gunderson's discussions, and he's eloquently described the range of and the power of faith and health collaborations that have occurred, and also with many charitable organizations around the country. Very successful work around patient activation and engagement work. We've heard lots of examples of that from this morning's session. We heard about a range of congregations and faith-based hospital systems we're aware of, certainly in our own communities. Community health centers and nonprofit organizations have been active for decades in addressing social determinants of health at many levels. In our background reading materials, we heard about examples of population health in action around transportation, support for health care and basic needs, healthy eating and active living examples we heard from Paul this morning. Grief counseling, senior care efforts that address social isolation, clinical navigator programs, respite, and adult daycare, as well as financial and legal counseling, all integral to the well-being of individuals and society. There's clearly an impressive depth and breadth of these partnerships that they represent really the full circle of health and of the full circle of the health and social service sphere. So I feel this urge here in a church, something I've always wanted to say and I never have been able to. Can I get an amen for that? I can cross it off my bucket list. Thank you very much. In that vein, our roundtable discussions have noted the power of major health policy initiatives like Medicaid waivers in delivering significant social benefits, improving the health and well-being of millions of Americans. Our next speaker brings a wealth of national and state experience on these issues to our discussion today. It's a pleasure to have with us Secretary Mandy Cohen, who is the Secretary of Health and Human Services for the state of North Carolina. Previously, she worked at CMS as the Chief Operating Officer and Chief of Staff, and was there for 7 years under several CMS directors, and so it's given her extensive experience. I think she's the perfect person to share with us her experiences. We're going to do this as a bit of a fireside chat, not certainly hoping and not to achieve what FDR did, but we'll just take a little slice of his experience. And we'll talk a little bit. Dr. Cohen will share her thoughts. I have a couple questions, and then we want to hear from all of you. And so it's a pleasure. Dr. Cohen, please.
Well, thank you, Gary, and it's great to well, it's great to be here, and I know that you've had a fantastically rich conversation in the morning. And so with the time we had, and we're doing so much work at the department, I thought I'd focus on a couple of areas. I wanted you to understand the lens by which I view our work at the department, because I think it really fits in well in what we've been talking about. And then I'll talk about a few specifics of how that lens translates into some of the work we're doing. But this all really starts all the way back for me, back when I was still training as a physician. I'm a primary care doctor. I was training up in Boston, and I was seeing a young woman. She was 24. She had health insurance. She had Blue Cross Blue Shield of Massachusetts insurance. She was a full-time college student, and she came in for what I normally see a lot of in my primary care clinic. She was losing weight. She generally wasn't feeling well, and she was losing her hair. And I was like, I got this. I'm almost done with training. I'm feeling like a pretty good doctor at this point. I did what doctors do. You ask some pretty invasive questions that you don't ask at parties about menstrual cycles and diarrhea, family history, and then I do what I felt most comfortable doing, which was ordering laboratory tests. So I had her get her blood drawn. I thought about anemia. I thought about Lyme disease. I thought about thyroid disorders. All of her lab tests came back normal first time around. So I'm seeing her for the second time. She looks ill. And we sort of talk further about what's going on, and I really couldn't put my finger on it. Now I've ordered a CAT scan of her belly, thinking maybe something's going wrong. Now I'm starting to think cancer and something else serious because she does look ill. Now the CAT scan was normal, so she's back for her third visit. I'm now 8 weeks into knowing her. And I'm like, where do I go from here? She still looks ill. She's back. She's not feeling well. And now I'm talking to my mentor, my preceptor. Where do I go here, mentor? We were discussing basically what specialist should I send her to next. When my medical tech who checked the patient in comes by, with the vital sheet, she checked her blood pressure and chit-chatted with the patient. She comes by and says, I really think you need to ask the patient if she has enough to eat. And that was a really hard moment, right? It's 8 weeks. Lots of tests, lots of spent money, and I hadn't asked her a very important question about her health. And I went to Yale for medical school. So it was a humbling moment for me. I was embarrassed. That I hadn't asked, that I hadn't put those pieces together. I was embarrassed that now I was going to go into her room and ask these questions. But I was also a bit nervous of what if the answer was I don't have enough to eat? What was I going to do about that? I had 5 patients in the waiting room. I was working in the hospital at other patients. What was I going to do? But I pulled myself together. I went back in the room and I asked her. What I would consider a completely unstandardized question. I just asked her, is something going on at home? Right? Which is not the question now in my mind, fast forward 15, 20 years later after that training, what I would want my fellow doctors to be doing, right? I asked her what was going on at home, and then it all sort of came out, luckily, that she was essentially living out of her car. All her money was going to tuition. She had just left a really, unfortunately, violent relationship. She didn't want to call her mom because mom had really loved the old boyfriend, and she just didn't even know how to ask for help. And she, in her own mind, hadn't put together the link between what was going on in sort of what she would consider, that's my personal life, right, and her health. She thought she even had that cognitive dissonance as I did. And that has really shaped for me how we need to move forward and how we think about health, right? I was thinking about health as health care. What lab tests could I order? What imaging could I do? What specialists could folks see? And not about health. And her health, and the most important question to ask her was really about food. And so that has really shaped my thinking about how we move forward. And as someone now who is charged with the health and well-being of the entire state of North Carolina, which can keep you up at night, I want to think differently about what health means. And it's not just buying health care, but if you look at my budget, I mostly buy health care. And not health. And so we're trying to think differently. And I will say, if you look at the health of North Carolina, it's not great. We're not even average amongst the states. We're below average. We're generally in the 30s here in North Carolina in terms of ranking out of 50 states. We're generally in the 30s, but then there's some really embarrassing statistics that do keep me up at night, whether it's 1 in 4 children here in North Carolina go to school hungry, whether it's 48% of the women here in North Carolina have experienced some sort of intimate partner violence. That ranks us 49th out of 50 states. Those are the kinds of things where we have to think differently about what we're doing. And I share that as the backdrop, really not as here I'm doing particular tactical things, but it is really about the framework by which I'm thinking about all of the decisions across the department. And I was sharing with some colleagues who are sitting in the back that even yesterday, I'm hoping that it goes beyond my department, right? I'm the person charged with health, but really all of the elected officials, that the leadership of the cabinet for Governor Cooper here have to think about health. So I was at a strategic planning conversation with the community about transportation. yesterday. And transportation is intimately linked with whether or not someone gets the health care they need, whether they can get to their job, whether we're creating greenways for people to bike and walk and be ultimately healthy. So even think like when you're wearing a hat like transportation, to think about those linkages. And that's where I think what is so special about what you've been doing here at this conference is we are really having a vision at the department of knitting together the healthcare space and the community resources. And so how do we all effectively steward our resources together and knit together that social services space, the community space, and what's going on in healthcare? And let's be honest, it's not about net new dollars, right? We all know that resources are tight everywhere, and healthcare makes up a huge portion of our state budget as it is. So this is really about how do we sit in the same room and talk about the same families and the same people that we're all interacting with, and how do we do that differently and better. And I think health systems, because of the way that we are trying to change the way in which we pay them, are starting to think differently about how they want to interact with the community, where before it was sort of like, don't ask the question because I don't want to get involved in that sort of space. I think there's definitely a change in how folks are doing. So let me make that concrete about what some of the things we're doing. So for example, in our Medicaid program, we are trying to do a couple of different things, again, to integrate this sense of bringing together our community resources and our healthcare resources closer together. So one is first we just have to ask the question. Don't do what I did and say, is something going on at home? But we have to ask real standardized questions about food insecurity, about housing insecurity, about transportation, and about violence. And so we've just finished a process of creating a standardized tool here in North Carolina based on a lot of very validated tools and work going on. And we want to deploy that across not just the Medicaid population, but our Medicare Advantage population, the commercial population here. And so we're working with our other payers and health systems to make that possible, because you have to ask the question. Then the second leg of the stool is, okay, you've asked the question, well, now folks need to be navigated to resources. And so we're working to stand up a resource platform that won't fix everyone's issues because we know there are gaps in resources, but at least allows us to, again, start to knit together the community resources and the healthcare resources. So there's a platform that links into an electronic health record that says, so if my patient had screened positive, as she did, for food insecurity, I could have said, I'm sending you to Food Bank X in the community, maybe at one of the local churches, and that I could send a message to that church to say, hey, expect Mrs. Smith. And if she doesn't come, let me know so that we can figure out what happened and we can make sure to, again, make those linkages and connections. So we're excited about that piece. And then the last leg of the stool is to actually pilot and learn what are the interventions that make most sense for folks who have these high needs that are not necessarily traditional health care needs, but are health needs. The traditional example I've given and we've tested here is with kids with asthma, right? So here in the eastern part of the state, we piloted a program where kids with severe asthma who ended up in the emergency room a lot, we went to their homes and we ripped up the carpet, we put down new carpet and gave them an air filter. And it's not surprising what happened. We saw a lot less kids in the emergency room. We saw mom and dad back at work because they weren't with their kids in the emergency room, kids at school. Plus, we were using less healthcare dollars, right? The emergency room's the most expensive place to care for folks. So we were using less resources, kids at school, mom and dad's back at work, health is better. So yeah, do I want to buy carpet with healthcare dollars? Absolutely. Right? But then what's the next? So I have good evidence around that, so we want to take that to scale. What are those next ones? We know, for example, for elderly populations who may be at risk at falls, right? We can go into their home and do certain interventions in their home to make sure that they're not at risk of falling. So trying to think through and tease through those examples for high-risk pregnant moms, for children who may experience who are experiencing chaos and violence and trauma in their life, and thinking about what are those interventions, home-based interventions and other, that makes most sense. So that's a lot of what we're doing. And I'd say the other piece of the work that's in Medicaid, but to try to knit some of these things together, is a focus on early childhood. And focus on particularly the 0 to 5 age cohort before you're getting to kindergarten. And for my department, we touch the lives of young children in so many ways. We pay for half the births in the state. We do all of the anticipatory guidance, like early intervention work. We pay for child care subsidies, NC Pre-K, Smart Start, all of those things run out of our department. So even we don't need anything new. We, the department, just have to work differently and better, again, to try to be more thoughtful about how are we really setting kids out on the best foot possible to be successful, no matter what zip code they're born in, right? And so we have these domains of making sure kids are healthy, that kids are nurtured and safe. We run child protective services too, and that they're ready to succeed, ready to learn once they get to kindergarten. And what are all of those things that need to happen 0 to 5? And frankly, it starts with mom and her health when she's pregnant. We have an embarrassingly high infant mortality rate here in North Carolina. National average is around 5. Here in North Carolina, we're 7. But if you go to rural western or eastern North Carolina, it's 15. So we're nearly triple the national average, right? So those are the places where it's a complex issue. It's related to poverty, and it's related to health, and it's that intersection where we're trying to make improvements. So why don't I stop there? That's a lot. And then happy to answer some questions. Thanks.
Thank you, Dr. Cohen. It's been said that a head and a heart approach, that combination is really important to begin to develop broad-based coalitions to get things done, to enact change. I think your example at the beginning, and being your candid story about your interactions with that patient so over 8 weeks, I think is an example. That's something that stayed with you, that you remembered and affects your work. I'm wondering, it's interesting to hear you say in the important position you're in, to be able to say that, can we replace carpet and air filtration equipment with healthcare dollars? And yes, we can. That is sort of anathema often to systems, but it's the creative thinking that we need to happen to make a difference. How are you able to, in your position, for those that are sort of keepers and protectors of the status quo, how are you able to reach beyond that to with your evidence and the head and the heart approach to tell folks there may be another way?
It's a great question, and there's often a lot of divide around healthcare, right? It's been a pretty partisan, contentious thing, and healthcare is very personal, and health is very personal to folks. And so I understand that, but I actually think that there is a lot of alignment about wanting us as individuals and us as communities to be healthy. And so when I think about, look, I'm appointed by a Democratic governor, but we have a Republican supermajority here in our General Assembly, but we have to work together for the people of North Carolina. And what I have found is there is a lot of alignment. What I hear a lot, for example, is a focus, a lot of concern from the legislature about rural health, about access to care, and about the issues of food deserts, transportation, broadband. And so there is, when you talk about it from that perspective, they get it immediately. I would also say children is a lot of the place where, right, they think about their own children and what they want for their children in terms of healthy, safe, and learning. And we're able to find that area of alignment. And on the health side, healthcare side, is as we change the way in which we pay for healthcare. So I'm a payer of healthcare, and so what we've been doing for a really long time is paying piece by piece by piece. And when you're a hospital and you get paid to keep your beds full, like, it's not malicious. That's their job, is to fill their beds. And so we're starting to pay differently, and so thus the emphasis of what their focus is changing. So you see hospital systems even here already in North Carolina thinking differently about what is their emphasis, not just about filling my beds, but what's going on in my community, where are my partners, right? And so maybe my message overall is a hopeful one, where I think folks are open and in a new way, in a different intentional way, to really make partnerships where there may have just been talk and lip service before. I actually think there's a lot more alignment. And look, and money and priorities drives that, and that's okay. But I think take advantage of this new opportunity. I think that is being driven by how we change the payment side to drive those partnerships together.
Thank you. From your perspective, what do you believe are the challenges and opportunities for, governmental, public health, and faith-based institutions to work together around real transformational initiatives? What advice would you have for all of us?
That's a big question. Well, one is, I think it goes back to where I was saying, is that we all have to sit in the same rooms together. I think there's a little bit of talking to ourselves that we need to break out of, right? Public health talks to public health. And the insurance executives talk to insurance executives, and hospital executives talk to, right? And I'm really trying, look, I'm a physician, but I have a public health background, and I was at CMS, and obviously I was running a very big insurance company, and I'm a payer now. So I'm trying to be a bridge between all of those, but we have to get out of just our silos. And I think folks have tried it in the past and maybe has failed right? But I think this is a different moment. And so I'd say we got to try again if you've tried, or try for the first time if you haven't, to really start talking to different partners, and not just the traditional public health partners, and not just the traditional, but think about those other partners in healthcare, and how can we get that alignment together. And if there are ways that we can facilitate that, using our bully pulpit, or just the way in which we do our work, that's what we're hoping to do.
Thank you. Thank you, Dr. Cohen. We have a few minutes of time here where we'd like to hear from all of you. And so I'm going to hand the mic to Alina. And if you've got questions for Dr. Cohen, please share them.
Thank you, Dr. Cohen, for your presentation and for your my name is Phyllis Meadows. I'm a senior fellow, member of the Round Table. Is this better? Okay. So my question is, you said, and I really appreciate your optimism that, this is a good time to start bridging those conversations. What do you think is different now than perhaps in the past? And how do you maintain that optimism in a society right now that's really feeling very divided?
So there's a couple of reasons why I think now is different. One is that the pressure around resources is real all over the place, and sometimes when that pressure comes, folks, it pushes people to a creative place, which is good, which means partnerships in my mind. I also think that what we have been trying to do, and now I'll wear my old CMS hat in the Medicare space, we actually, right, those are huge dollars, right, that drive a lot of the work in healthcare. And as I was saying, we have been really trying, it started with Medicare, to change the way in which we pay and move those dollars to get folks to think differently about healthcare more broadly to that health space. So I think it's the combination of dollars moving differently, resources being tight, sort of forcing that creativity, and then places like here, like North Carolina, we're really trying to take things to scale. and create that infrastructure to allow that knitting together to happen and use it as part of everything that we are doing. And look, it's not happening everywhere, but I'm hoping we can show here in North Carolina that if we do take those things to scale and we have a state that is aligned around health and we're prioritizing resources in that way, and I can bring my health systems along, I bring my other payers along, I bring our doctors and nurses and others, and then bring the social services and the community resources to get right. I see the pieces here in North Carolina, right? It's so fun. Like I see all the pieces of the puzzle, but they haven't yet intersected, but we're slowly trying to put them together. But I hope that answers your question.
Secretary Cohen, I'm Missy. I'm with CareNet Counseling with Wake Forest Baptist Health. I was very encouraged to hear for you to address concerns about our rates of intimate partner violence, trauma. I would love to hear ideas, dreams about those innovative interventions for prevention of trauma.
It's a really great question, and probably not one that I could do justice to in this short time. But what I would say is we're trying to look at 100% on the prevention side, which we know involve factors related to substance abuse disorder, overall stress related to poverty, the lack of job opportunities, which starts, and you try to get back upstream and upstream and upstream. It's like, how do you get to the root of all of these things, which is sort of what we're trying to get to. And it's never going to be one thing, right? Because these are such complex issues. But we are trying to think as upstream as possible, and where are those investments. But what I'd also say is, in addition to prevention, we are trying to think about what is it that makes kids resilient. And families resilient, because trauma is going to be part of our experience. And are there ways in which we can give folks tools to ascend beyond that trauma? And I don't think we have enough research to know what that is yet. I've been poking at it to say, like, well, what should we invest in, and how do we make these kids stronger that have already experienced something? I think the prevention is exactly right. Hopefully they never get there in the first place. But how do we know some kids experience really bad trauma and then are hugely successful? And what was it? A teacher, a pastor, an important person in their life, or what was it that we put around that person, that family, that allowed them to be resilient? So we're doing a lot of thinking on that, and that's where I hope my academic partners are going to help us do some work in this space. But the prevention side is really a tough one, but multifactorial, and one we're trying to come at from many, many different directions. Okay, thank you.